Now, moving on to our first section, that is, we'll be discussing the spinal cord injuries, what are the stable ones and what are the unstable ones. We'll be discussing the Dennis classification, its pathophysiology, the healing mechanism, and early management of the spinal cord injuries, especially in the case of a polytrauma patient. So if you see, this is a diagram of the vertebra of the spinal cord, but actually it was the Dennis which classified, gave a column theory on this, and there's this is according to Dennis, the spinal cord consists of three columns. There's an anterior column, then there's a posterior column, and there's a middle column in between them. The anterior column is formed by the anterior longitudinal ligament, which is attached on the anterior side of the vertebral body, along with the anterior two-thirds of the vertebral body forms the anterior column. The posterior one-third, along with the posterior longitudinal ligament, forms the middle column, and all other elements of the spine, which include the transverse processes, the spinous processes, the pedicle, the facet joints, and laminae, and all these structures, along with the posterior longitudinal ligaments. There are multiple interspinous ligaments, facet joint ligaments, transverse spinous ligaments. All these come into the posterior column. These are called as posterior elements, the middle column, and the anterior column. Now, when we are discussing the stable injuries, usually involve the anterior column only. Whether the burst fracture or compression fractures of the anterior column, they are usually stable because there is not a lot of ligamentous disruption. Unstable injuries actually involve the middle and the posterior column. When posterior or middle column is involved, it usually is unstable because there are multiple associated ligamentous injuries as well. And that makes the spinal fracture unstable, which is why it is important to know when we are dealing with stable fractures, we can treat them conservatively with bed rest, with drugs for the analgesics and painkillers, and then we can slowly rehabilitate the patients. But the problem with the unstable fracture is that there is always a doubt of neurological compromise, even if at this moment the patient is neurologically intact. Unstable injury can eventually lead to canal compromise and a complete spinal cord or injury, which could be devastating. Patient can have a quadriplegia or a paraplegia for life. So that first and foremost important is to recognize whether this pattern of the fracture is stable or unstable. If it's unstable, you have to be very careful with the management, and you have to go for some kind of a management to make it more stable. Now, there's an AO and ASIF classification. Actually divides the fracture pattern into type A, B, and C. There are three types of fractures. It also involves not only the columns but also involves the mechanism of the injury. Usually type A are actually anterior column compression fractures, which tend to be stable. And how would they? There would be actually the flexion injury. There would be severe bending of the spine in the forward flexion. This would lead to anterior column compression fractures. This is going to be the usually stable and type A injuries. Now, coming to the type B injuries, involve anterior and posterior column with distraction, and these are unstable injuries. There's usually flexion distraction injuries in which there is a flexion and it is actually the vertebra come like this, and then they get distracted as well. This is it's further subdivided into B1, B2, B3, depending upon whether the only osseous elements are involved or ligamentous elements are involved as well. So it's most commonly when there is a flexion distraction injury, this becomes type B injury. Type C as again mechanism of injury involving along with the column. That is, it not only involves the two columns, that is usually the anterior to posterior, along middle and posterior column, but it also involves a rotational element as well, such that injuries are with rotation or shear. These are unstable variety. That is, the fractures vertebra fractured and actually rotated over it. Or this is, if you see it in AP plane, actually the vertebra are sheared off or separated by this, and this is why they are unstable, because they usually present with a complete spinal cord injury. Now, coming to the pathophysiology, you all understand the vertebrae are actually made up of spinal cord. There's inside the spinal cord, it contains ascending and descending tracts. Ascending tracts are all mostly sensory, and they're going up into the brain to give all the feedback which is coming from the body. And there are descending motor tracts which actually come down as form of corticospinal tract. So there is other mechanism as well. There is sympathetic chains as well, which are coming from the dorsal lumbar region, that is thoracic and lumbar region of the spine. And then there are then there are other parasympathetic as well, outflow as well, which is in the cervical and the sacral level as well. So we have to understand it. Then there's motor as well as sensory component as well as autonomic component of the spine. So what are the primary changes and secondary changes which occur? It depends upon actually the mechanism of injury. If it's a traction or a avulsion injury, this could be simple when a patient has actually resulted in a certain deceleration force and there is a seat belt there and some part of the body is actually held back by the seat belt. The patient lunges forward. This can cause certain deceleration, can cause some kind of traction avulsion type of injury, especially very common with the case of chance fractures. There could be direct injury, although it's very rare, but direct injury could be in form of a stab or a bullet or a projectile directly heading into the spine in form of causing a burst fracture or an anterior column fracture. Mostly it's the indirect injury. Indirect injury is actually the maximum flexion distraction or extension distraction which is actually occurring at the different levels of the spine, because usually whenever there is transition in from thoracolumbar spine, there is actually the weakest area, and as a result when there is sudden deceleration, the lumbar spine remains intact and thoracic spine flexes forward over the lumbar spine, leading to a chance fracture of thoracolumbar region. Now this is not a direct injury, but this is indirect injury which is actually causing the problem over the spinal cord. Similarly, with a severe form of neck extension or flexion can lead to cervical vertebrae fracture, which can also be due to not that the direct injury but indirectly due to so much force and strain be placed on these ligaments, and this results in the disruption of the ligaments leading to traction, avulsion, rotational type of injuries. Now coming to the healing. Spinal cord injuries, both there could be bony or soft tissue. When we call it soft tissue means the ligaments which are actually stabilizing the spine. There's anterior longitudinal ligament, posterior longitudinal ligament, and multiple posterior elements are actually multiple ligaments are involved over there as well. Now coming to the bony injuries, they usually heal, but if they are left with to heal on their own, usually develop kyphosis or loss of height. Why? Because if there is a burst fracture, there will definitely loss of height later on, or if it's an anterior wedge type fracture, this would lead to a kyphotic element. If you see this as the photo of a burst fracture, which is showing actually an X-ray of the lumbar spine, it's L543 and L2 involving the L2 vertebra. And you can appreciate that eventually once this would heal, there would definitely some degree or some loss of height would definitely be available. Now coming to the ligamentous injuries. This usually seldom heal to a stable state, so this is important and lead to progressive kyphosis, chronic back pain, and further neurological sequelae. Now, what is important? That is why when we were discussing the stability and instability, that was important because these ligamentous injuries will not heal and eventually will lead to neurological compromise. So when there are associated ligamentous injuries, we need to fix the spinal cord or fix the vertebra so that they stay in place in a proper way. Now coming to the early management. Usually these patients are there, although this could be a direct trauma in form of a bullet injury or firearm injury or a stab to the spine, but most commonly there is associated with polytrauma. And when there are polytrauma associated with spinal cord injury, early management is as always per ATLS guidelines. That is, you assess the airway and resuscitate it, assess airway and cervical spine immobilization. Whether there is injury or not, this is a mandatory sign that you stabilize the cervical spine. And how do we cervical spine stabilize is by putting the sandbags along with it, or applying a rigid collar to it, or at least putting the patient in this position on a spinal board and the collar is actually cervical collar is in place. That is, even if there is no injury, initial treatment is always stabilize the cervical spine and then go towards the breathing. Breathing is assessed, adequate oxygen and perfusion is maintained. If there is no associated breathing and circulatory problems, then you can, when we come to the disability, that is the D form, then we are assessing the neurological status of the patient, and that is the spinal precautions are always taken until the patient is resuscitated, life-threatening injury management, and then you are sure that you have enough time to assess the neurological injuries. If there are associated life-threatening injuries such as pneumothorax, as per ATLS guideline, they take the priority. Immobilization of cervical spine is done by a collar, and immobilization of whole of the spine is done by use of a spinal board. There is a term called as log roll, and that is why it is done is whenever the patient is examined or moved in the trauma center, especially in the case of skull trauma, it's always moved in the form of a log roll. That is, the whole body moves either to one side in one direction at the same time. This is actually to prevent this kind of a torsional injury. If there was an incomplete spinal cord injury and half of the body is actually moved forward or rotated first and other body is rotated later, this can actually result in a twisting rotational type C type of an injury of the incomplete spinal cord injury can get converted to a complete spinal cord injury. So whenever we are dealing with spinal cord injury patients, two things mandatory, that is a cervical collar, immobilization of cervical spine, and use of spinal board, as well as log rolling of the patient. This is a mandatory function and has to be done in the case of early management of the spinal cord injuries. Now, as I told you, temporary immobilization with a semi-rigid collar and sandbags is mandatory. Sandbags can only be used if the collar is not available and or by roadside for temporary. Just by the time the help arrives and the rescue operations are continued, you can use sandbag. But usually, the most common method is to use of a cervical collar. And transferring a spinal cord injury patient to CT or MRI, that is also mandatory. It must be done. Log rolling with spinal precaution. That is why, because we do not want to convert an incomplete spinal cord injury into a complete spinal cord injury. Patient transfer to a pressure care mattress as soon as possible. Now the problem with this spinal cord board is it's very rigid. Although it's rigid in itself, that doesn't really have a problem. It aggravates the spinal cord injury. But the problem is that it really causes a lot of bed sores. Even 45 minutes to 1 hour of a patient, if it's been kept on this, to be lead to a serious kind of a bed sore, especially over the sacrum area, especially over the heel and occiput. This is important that patient should be shifted as early as possible after the assessment has been made to the pressure care mattress, because otherwise patient will be kept on the spinal board for a longer time, will eventually develop bed sores. In this section, we have briefly discussed the classification of the spinal cord injuries. That is actually the Dennis defined it as a three-column theory. That was anterior column, middle column, and posterior column. Isolated anterior column injuries are all stable. Middle and posterior column injuries really have multiple ligamentous injuries as well, and they are mostly unstable. When we are dealing with unstable injuries, we need to first understand that early management of any spinal cord injury patient is as per ATLS guideline, that is the airway and cervical spine immobilization. Then we go on to the breathing and circulation. Once the life-threatening injuries are settled down, they are taken care of, then we can, after the assessing the neurological deficit and everything, environment and temperature and control is taken in the patient, then we can go for the assessment of the spinal cord injuries, and that is usually only and only after the life-threatening injuries are management. The rule is that cervical spine must be immobilized whether there is associated injuries or not, because that is it. And how to actually stabilize the cervical spine is by use of spinal board. Whenever the patient is being transferred towards the CT or MRI inside a trauma center or towards the trauma center, it must be transferred on the spinal board, and whenever we are moving the patient, it must be log rolled in one direction at one time, so that there is no does not convert an incomplete spinal cord injury to complete spinal cord injury. Thank you very much. Keep watching sqadia.com.